Good evening, everyone, and welcome to our webinar this evening, which is the second of a three-part series of events exploring the topic of autism as experienced by autistic women and girls. My name is 𝗔 𝗔𝗂𝗏𝘂𝗧 and I'm a chartered psychologist. I work in a private practice which carries out autism assessments with children and adults and provides support for autistic children and adults. I also work as part of the psychology team at the 𝘦𝘷𝘦𝘯𝘐 Dublin Education and Training Board. This event is brought to you as part of the St. John of God's Research Foundation's Learning Exchange Series of St. John of God's Research Foundation in collaboration with the Autism Special Interest Group of the Psychological Society of Ireland and the Psychology Department of 𝘦𝘩𝘰 Clinic Services. This evening event provides some pre-recorded and some live presentations. Throughout, you can submit your questions and comments to the Q&A button at the bottom of the screen. At the end of the presentation, we'll be holding a live panel discussion with our contributors, and we will try and get to as many of your questions as possible. Unfortunately, we won't be able to respond to anybody raising their hands, so please make sure you use the Q&A function instead. If you're tweeting, please use the hashtag #AutismWebinar and make sure that you tag us at PSI Autism SIG and at Research SJOG. If you require CPD points from the PSI, please email autism@psychologicalsociety.ie after the event. We'll have a couple of comfort breaks throughout this session, so you'll have some time to stretch your legs. We'll do our best to keep within the time and hopefully everything will run as smoothly as possible. Can I remind you to please not to share your link with anybody else? The event is completely booked out, and if you share your link with somebody who's not registered, it means somebody who is registered won't be able to access their place. We will be recording the event, and the recording will be made available publicly. Now, without any further delay, I'm delighted to launch proceedings and welcome our first speaker, Vanessa Lacey. Vanessa has worked with TENE since 2010. Her current role is as their Health and Education Manager. As part of this role, she designs and delivers transgender-related training for healthcare professionals throughout Ireland. Vanessa has a BA degree in psychology and has recently passed her PhD Viva examination. Congratulations, Vanessa. She's worked on numerous occasions with media and is a published author both in media and academically. She's a member of various HSE and TUSLA committees on both national and regional level. And very importantly, she's also a very proud parent. Over to you, Vanessa.
Thanks very much. Thanks a million, Jacinta. That was the very important part there. So thanks a million. Thanks for the invite. And I just get up my screen there. So you can see that there, I suppose you can. Yeah. Okay. So I'm going to present for the next 15 minutes or so. In terms of co-occurrence, in terms of gender dysphoria or gender incongruence, and ADHD, autism spectrum disorders, and maybe ODD, in terms of the co-occurrence experience from transgender people. I suppose when I was first asked to present at the conference, number one, I was delighted, but the name of it was a little bit jarring. For me, given that some of our young people who do experience co-occurring difficulties, or I'm kind of afraid to say disorders, do not identify as either girls or women. So I think just to mention that point on that. And I think really sometimes in this photograph here on the bottom of someone say, what does a transgender man look like? So I picked out an old friend from San Francisco who was quite famous in the area of transgender legal issues and healthcare, Dr. Jameson Green. And when people refer to girls and women, especially, and then you look at someone like Jameson, and he definitely doesn't look like a girl or a woman. So but it's absolutely wonderful to be here. So I'm just going to speak in the next few minutes about co-occurrences I've mentioned, some of the gender difference, some of the theories and social factors, and some of the guidelines. I suppose that's a really crucial area for us, that sometimes there's a perception if a young person or an older person has experience of gender variance or gender incongruence or dysphoria, and also a diagnosis of ASD, then maybe it's because of the ASD and they don't really have gender variance or gender incongruence. So I think it would be, certainly good to go through then some of the guidelines from the research, and that there is quite a bit actually throughout the globe. So as I mentioned, just like any population, trans people also experience co-occurring issues. Unfortunately, we are a stigmatized community, and we're marginalized. We experience minority stress because we're marginalized, and we would absolutely experience quite a lot of stigma. So if there is like co-occurring issues or anything else going on, it can be because of who we are in the world. Certainly, I would like to think that we've come further along the lines in terms of lesbian and gay people, but transgender people and transgender identities, unfortunately, would hold a lot of stigma. Just to mention, sometimes just to be identifying as transgender or gender transitioning in young people and adults, it's again perceived through a negative lens, which again can add into negative factors and how we are treated in healthcare. So I think, just to mention the point that, many of us go on to have very content lives, not wholly negative. My own research was in the experiences of adult transgender women and families of adult transgender women relation to grief and loss, and really it came down to the dominant theme of ambiguous loss experienced from both. But there was also an element of ambiguous gain. Again, we look at the negative aspect, of transgender people's identities often, where there's also quite a positive that you can live your authentic self. So yes, there is a co-occurrence, and the research would suggest that. And there's many research studies at the moment from different countries, from different continents, from Australia to America, to some of the main ones here in Finland, from their gender identity teams, that there is a high co-occurrence of ASD and gender dysphoria within young people, certainly. De Vries et al. And De Vries et al. Is Annelou De Vries, and she's a psychiatrist as part of the Amsterdam team, which is one of the main centers in the world, especially for research that comes out of there. And Annelou De Vries, and I know you're going back 10 years or 11 years with this, but again, it can be more complex, I suppose. So in terms of just to disentangle, I suppose, an experience of gender dysphoria from ASD or other co-occurring issues is certainly a very important factor to understand. Annelou De Vries again et al. Identified not only that there was high rates of co-occurring issues in terms of gender dysphoria and ASD, but also in terms of ADHD and ODD. Ken Zucker reported in 2017. He's one of the main researchers, I suppose, in transgender healthcare from Canada. Many trans people wouldn't be a fan of Ken's work, and he can be quite look at it through a negative view. But his study here, he's quite a great researcher. But in terms of his findings here, that many people across the board, in terms of different clinical difficulties, can be found in a range of different areas. So it's not just in relation to gender dysphoria. This study here, again from Van der Meissen, again in Holland, looked at the differences in terms of associations between gender variance and specific ASD characteristics. And again, looking at the difference in terms of how boys are raised and how girls are raised, and how boys start presenting in a gender variant way, and how girls started presenting in a gender variant way, and how that, again, if there's a diagnosis of ASD or other co-occurring issues, again, how that can manifest, I suppose, in the young person experiencing them. Some of the theories, this theory here from Baron Cohen, who was actually the cousin of Sacha Baron Cohen, looked at empathizing and systemizing theory. I remember being at a conference in London, actually, and he was presenting, and it was very interesting in terms of his extreme male brain theory in terms of transgender people, in terms of that people on the ASD spectrum don't have high rates of empathy for people, find it hard to have eye contact, and this is his way of explaining trans men or trans masculine people, which is a really interesting theory, but it doesn't translate to trans women, the same theory. So I suppose it's an interesting theory, but at the same time, how do you understand that in terms of trans women who were assigned male at birth and then identifying as women? So maybe it doesn't translate as good, but again, it's a saturation of testosterone within the brain during them semesters. So in terms of the social factor hypothesis, I suppose, so you know, in terms of my experience, I suppose, and I might speak to this one in terms of my experience working with, I suppose, many families of transgender people and transgender people themselves. And, you know, I've worked with hundreds over the years. And, you know, I have worked with many families with children with and young people with diagnosis of ASD and other co-occurring issues. And some have experienced this from when they were, you know, very young, and the families would talk about their stories in terms of the young person, which they're often asked to do in terms of assessments, to talk about their story of their young person, where they could not conform to societal norms of what their assigned gender was, and again being overly diagnosed in terms of being on the ASD spectrum because of their persistence that they're not girls, that they're boys, and again, you know, it's you know, because and I feel because there's not a massive amount of people in Ireland trained in the area, and there's certainly not a multidisciplinary team in terms of Ireland either, that often these situations are missed. So in terms of young people, adolescents who are also on the spectrum and who recently identified as transgender and looking to start on medical interventions, it's quite different to a situation where a young person, a family can recount stories of a 3 or 4 or 5 or 6 or 7-year-old child, but when they're put in the same waiting list to be seen, it is quite concerning. Whereas a more straightforward situation, or a more straightforward, I hate to say, diagnosis, whereas on the other side, it's a little bit more complex. In terms of guidelines, I am really delighted to say that there is some guidelines here from Strang et al, and that et al is quite extensive, and they would look at that to ensure that the therapists in both have experience in both ASD and gender dysphoria when diagnoses are done. In an ideal world where there's a multidisciplinary team, and it's a key thing here in an Irish context, where as much as we do have a service per se in Our Lady's Children's Hospital in Crumlin, it is very under-resourced. The only position in there at the moment, I think, is admin and a part-time social care worker, and there's a locum pediatric endocrinologist, but it is massively under-resourced, and especially when there needs to have, in terms of the International Protocol for Medical Interventions for Young People, to have at least 6 robust assessments, and if there is co-occurring issues in there, them assessments need to be extended. So in a situation in Ireland, we are not equipped for that, and we have been, I suppose, buying our assessments from the Tavistock Clinic in London, which have unfortunately had their own difficulties of late, and I can't really see the Tavistock people being involved in our service maybe in 6 or 8 months' time, certainly not in 12 months' time. But I would like then that we would be in a position that we have filled some of them posts, and we have that multidisciplinary team, and we can absolutely look at meeting the recommendations from the like of Strang et al.'s guidelines for working with transgender people. So again, just to mention that there is guidelines. Guidelines are available, so I'm not going to go through them, but just to mention strongly that there is absolutely co-occurring issues within the transgender community. It should not be a reason to exclude, I suppose, people who are also experiencing and are also on the ASD spectrum. That's a really important point to make tonight. It's harder to comprehend long-term risks and complication consenting for treatment. So I think to be very straight with young transgender people, if they're going through, or people who identify in a different gender during assessments, especially if there's ASD, be very upfront and explain what the treatments might encompass, because sometimes there is unrealistic expectations. So as much as I'd love to have another half an hour to speak about unrealistic expectations, I know I have to jump on to the next slide. So the conclusion I'd like to make is there is multiple hypotheses and that may play a role in GD and ASD co-occurrence. An individual approach is best practice and should be taken and should be considered in Ireland and should be done in Ireland. That's what we should be doing as best practice. At the moment, we have no practice. There are many possible outcomes that can unfold over time. Again, allowing the person explain their story. Not all people go on to have medical interventions. Less than 50% of people, of Irish patients who are being seen by the Tavistock, go on to have medical interventions at all. So that would suggest the assessments are working quite well there with them. An extended period of assessments, which I've mentioned. Decisions around gender may emerge gradually as the young person increases in the ability to think realistically, and that's the thing I've mentioned earlier on, thinking realistically for the future, what this is going to mean for them, and explain. We need more research in Ireland. I'm delighted to say that there is research being currently done by 𝘱𝘁 𝘀𝗻 and Dr. Anne Keogh, and I really look forward to the findings of that. I know that the data has already been collected, so 𝘱𝘁 will be doing the analysis, I suppose, in the next few weeks. So that best to look to her, and look forward to seeing that. And finally, Ireland needs a proper multidisciplinary team, gender service for young people, which we don't have, and is causing enormous stress for people, but we absolutely have co-occurring issues. And thank you so much. I'm so sorry that I had to rush so fast through the presentation and change into slideshow. So thank you so much, Jacinta.
Thank you, Vanessa, for kicking off our event with that wonderful presentation. I'm really looking forward to hearing more from Vanessa during our panel discussion later. Now it is my pleasure to introduce our next guest, Dr. Faye Murphy. Faye is a principal clinical psychologist and head of the Department of Psychology in 𝘧ine Child and Adolescent Mental Health Services, and she's also an honorary tutor at the School of Psychology, Trinity College Dublin. She completed her undergraduate degree in Trinity, followed by a master's in neuroscience in the Institute of Psychiatry and a doctorate in clinical psychology in the University of London Royal Holloway. Prior to her return to Ireland in 2014, she spent 11 years as a highly specialised clinical psychologist in Great Ormond Street Hospital in London. She has a special interest in feeding and eating disorders, as well as children and young people's cognitive functioning, and the impact this has on their mental health.
Thanks, Jacinta. Is that okay? Can everyone hear me? Okay, thanks very much for that introduction. As Jacinta said, my name is Faye Murphy and I'm the lead psychologist in 𝘧ine CAM, which provides CAM services for a huge amount of South Dublin and West Wicklow, comprised of 8 teams across 5 sites. And as Jacinta mentioned, prior to taking up my role in 𝘧ine CAMs, I worked in the Feeding and Eating Disorder Service in Great Ormond Street Hospital. And in that role, I saw a huge number of children and young people with co-occurring autism spectrum disorders, primarily presenting to the feeding disorder service, but also presenting to the eating disorder service. And very often in that context, this would be the first presentation of young people to services. In that, what I mean by that is that they would usually have undiagnosed autism at that point, and their at that point in their childhoods or in their adolescence, their eating difficulties would often be the most concerning aspect of their presentation. And as part of our assessment, we would suspect co-occurring autism, and we were lucky enough to have a specialist service to diagnose that for us. In 𝘠𝘠𝘂𝗰𝗂𝗂𝗏, we don't have a specialist autism service, but we are very skilled, and we're very interested in autism spectrum disorders and a wide range of co-occurring conditions, and we have a fairly robust autism assessment pathway. So now that I work in general CAMHS, I do continue to have a special interest both in feeding and eating disorders, as well as in the diagnosis and support of young people presenting to CAMHS with ASD, which keeps me busy, as there seems to be a never-ending demand for our service and for help with these issues. So today I'm going to focus on two co-occurring conditions that I have experience of assessing and treating. One is anorexia nervosa and the other is ARFID in women and girls with ASD. So ARFID, I'm sure in the presentations last week you've heard a lot about diagnostic criteria, and I'm going to talk about our ARFID diagnostic criteria. I'll quickly talk about common presentations in children and young people with autism, what ARFID might look like. ARFID stands for, I should say, Avoidant Restrictive Food Intake Disorder. And then I'll think about treatment implications when there's co-occurring autism. And then I'll go on and have a brief overview of anorexia nervosa, including diagnostic criteria, think about common presentations in women and girls and treatment implications. And then I'll consider, if I haven't completely run out of time, the treatment considerations common to both ARFID and AN when there's co-occurring ASD. So the DSM-5 feeding and eating disorders category changed from DSM-4, and these are the subcategories. And today, as I say, I will focus on avoidant restrictive food intake disorder and anorexia nervosa. So ARFID, avoidant restrictive food intake disorder, obviously it predated its introduction into DSM-5, but there was there were different terminology used in different settings, and the field was very much hampered by there not being agreed diagnostic criteria for this group of presenting difficulties. So the criteria are disturbance of feeding or eating, which is characterized by lack of interest in eating or food, avoidance based on sensory characteristics of food, and fear of consequences of eating. And in co-occurring autism, we'd be mostly thinking about the avoidance based on sensory characteristics of food. There's persistent failure to meet the individual's needs in terms of nutritional adequacy and/or overall energy intake. And this might be associated with weight loss, nutritional deficiency, dependence on tube feeds, or impairment in psychosocial functioning. And this was really important in the field because prior to that, weight loss was an essential criterion, and many children we know who have very, very restricted diets could actually have normal weight or might even be overweight, and so they didn't meet criteria for any sort of condition despite maybe being 11 years old and drinking from a baby's bottle or whatever. So this was a great change, and it brought in a huge number of kids who wouldn't have met criteria in the previous DSM-4. So limited food intake isn't due to food not being available, and the restriction and avoidance is different to anorexia or bulimia because there are no associated weight or shape concerns. The young people are not trying to keep their weight down, and it's not explained by another medical condition. Okay, it can co-occur with another condition, but only warrants diagnosis if it needs treatment in its own right. Okay, so what might it look like clinically? It might look like a sensory-based aversion to the sight, smell, taste, texture, temperature, or a combination thereof of the majority of foods, leading to an extremely restricted diet and a negative impact on social development. So for example, I said earlier, like a reliance on baby food or purees in an older child, and there's sometimes an associated fear of choking or swallowing, and it's consistent with the rigidity and insistence on sameness and routines that's sometimes seen in ASD. There are often pronounced sensory issues, so young people or children with these sorts of difficulties can often get stuck on one brand. They can't move from Kellogg's cornflakes to Little cornflakes, for example. The smells are very potent to them, and the texture of food can be really aversive. And then poor nutritional intake in turn can compound the behavioural difficulties that might be part of their autism, but this should really be viewed as a problem in its own right that deserves attention and intervention, and it can be extreme and very difficult to treat. So there's a theoretical model here that is thought to underpin ARFID, and if you look for the purposes of ASD, the biological predisposition in this slide would be the sensory sensitivity, which would lead to negative feelings and predictions about the consequences of eating. And then there'd be food restriction that would feed back into those negative feelings and predictions, but also lead to potentially nutritional compromise, which in turn might lead back to food restriction. Presentations associated. So when we think about treatment of these kids, how do we treat them? How do we approach it? Presentations that are associated with really strong sensory aversion can be particularly difficult to treat. The first thing we need to do is ensure nutritional sufficiency, as restricted diets can be extreme and can be associated with all sorts of negative consequences. But if the young person is motivated to change, you can approach following a collaboratively set goals using an exposure hierarchy in vivo. So by which I mean, that's a fancy way of saying helping the young person to introduce nutritionally beneficial new foods in the clinic and using behavioural experiments outside of the clinic. And I have done this several times. We've been in the local McDonald's and various other places with young people trying to introduce new foods into their diets and in more socially acceptable environments. And sometimes they can be very much helped by the use of adjunctive relaxation techniques if there's high anxiety. So I quickly move on to anorexia nervosa. I could talk about this all day, so it's absolute torture trying to fit it into 15 minutes. The DSM-5 criteria for anorexia nervosa are persistent restriction of energy intake leading to significantly low body weight, an intense fear of gaining weight, which kind of sets it apart from ARFID in that children with ARFID aren't concerned about weight gain or weight loss, persistent behaviour that interferes with weight gain, and disturbance in the way one's body weight or shape is experienced, and then an undue influence of body shape and weight on self-evaluation. So you overvalue the shape of your body. It contributes in an extreme way to your evaluation of yourself, and a persistent lack of recognition of the seriousness of the current low body weight. And so anorexia in women and girls with ASD, in terms of research and prevalence, then as far back as 1983, Christopher Gilberg suggested that anorexia might be the female form of autism based on his observation of families of people with ASD. And in 2012, a longitudinal study of AN from the same group identified an important minority of subjects with social communication deficits consistent with the then DSM-4 criteria for autism. I remember 20 years ago as a research assistant at the Maudsley, there was a huge amount of interest in autism and anorexia when I worked in the specialist unit there. And I was slightly dismayed to see that the field hasn't moved on enormously since then in terms of how to approach these difficulties and what treatment adaptations might be helpful. Later studies have consistently shown that 20 to 35% of women with anorexia nervosa meet criteria for autism, which, when we think about the prevalence of autism as being in around 1%, is really quite striking. So why are the rates so high, you might ask? And some researchers have suggested that it could be the effects of starvation. So one theory is that autism traits are secondary to starvation, and they lead to a pseudo-autistic presentation through a starvation-induced cognitive rigidity, for example. However, this is unlikely because prevalence rates have been shown to remain high in those who've recovered from anorexia, and retrospective studies have indicated that autism traits predate the onset of anorexia in a significant young number of women and girls. So that the autism, for example, studies where they've interviewed parents of people with anorexia nervosa, they're able to give kind of accounts of their development that precedes the onset of the anorexia. So this is a fantastic new model by these authors, just really recently published, that sort of sets out how these things might fit together. So you'll see to the left the areas of autism related to difficulty, so sensory sensitivity I've mentioned, interoceptive ability related to eating, digestion, bodily changes, understanding and regulating emotions, social interaction and relationships, intolerance of uncertainty, rigidity.
Sorry, just letting you know you're 2 minutes.
I have 2 minutes left.
Yeah.
Oh, goodness me. Okay. I will fit. I'll have to hurry up. Okay. So that those difficulties can, there's a direct pathway in this model that restrictive eating becomes a coping mechanism to deal with some of these phenomena associated with ASD, and then the starvation feeds back into those. Or there's an indirect pathway where there are moderating factors like bullying, or, for example, unrecognized autism, and then there's the negative emotional consequences can come into play there. Mental health difficulties, impacts on sense of self, and feeling overwhelmed. Okay, so we also know, what are the implications for treatment? In my last 2 minutes, we know that of all anorexic patients, those with high autistic traits benefit the least from current treatment approaches and have particularly low recovery rates and levels of functioning. So they also require greater treatment augmentation, so that might be more sessions or inpatient treatment. So it's important, therefore, that ASD is identified, addressed, and appropriate treatment adaptations are made and adjunctive treatments are offered. For example, cognitive remediation where indicated. You can look up cognitive remediation. I have a bit of a slide on it, but I don't have time to go into it in more detail, but it's using neuroscientific findings to in clinical practice to change thinking styles. It's not a treatment in itself, but it's an adjunct to, for example, cognitive behavior therapy, and it addresses some of the more rigid thinking styles and targets the neuropsychological phenomena that we know are common in women with both anorexia and autism. And alexithymia is another very interesting area. There's a very recent study that you might want to look at that looks like alexithymia might be the key to the elevated risk of eating disorders in women with autism. And alexithymia is a difficulty in identifying and labeling one's own emotions. I was going to talk a bit about ARFID versus AN, but I've run out of time. So the take-home message would be that adjunctive treatments are all certainly promising. There's a bit of a way to go with them, but that I think all clinicians should have parallel training who are treating anorexia and ARFID and similar difficulties should have parallel training in identifying autism, assessing autism, and adapting treatments accordingly. Okay, thanks very much.
Thanks for that, Faye, and we look forward to going further into some of the topics that you raised at our panel discussion later. And now for our last contributor before our first break, I'm pleased to introduce Dr. Mary Dougherty. Mary is an autistic consultant anaesthetist with a special interest in regional anaesthesia. In her spare time, she researches barriers to healthcare for autistic adults and experiences of autistic adults using mental health services. She's a founder of the peer support and advocacy group, Autistic Doctors International. She's a member of the Royal College of Psychiatrists Working Group that produced the CR228, the Psychiatric Management of Autism in Adults. And she has written numerous book chapters, articles, and blogs on autism. She's working with the Association of Anaesthetists to develop support for autistic trainees in anesthesia. She is also a qualified ski instructor and teaches at the Ski Club of Ireland. Mary's talk tonight will explore the experience of autistic adults accessing primary care and mental health services, including access barriers and their consequences, along with practical solutions to facilitate engagement with healthcare services. Over to you, Mary.
Thanks, Jacinta. Let's see if I can oops, daisies. Let me see if I can share this. Hold on now. Okay, you should be able to see my slides there now. Okay, so I'm going to give an overview of what's known about the health of autistic people, and then share some preliminary data from two of my research projects, barriers to primary healthcare for autistic adults and the experiences accessing mental health services. But first, I want to start by addressing a question that was raised at last week's webinar, because this touches on my current work on peer support and advocacy for autistic doctors. And the question was, should diagnostic teams have autistic members? And the answer is many already do. Autistic professionals exist in all fields. In healthcare, we have autistic doctors, nurses, pharmacists, occupational therapists, speech and language therapists, autistic psychologists, psychotherapists, and many are thriving in a supportive environment. Many more are seriously struggling, but most of us don't disclose our diagnosis due to stigma and unconscious bias. So lots of you may be working alongside autistic colleagues already, or indeed you may be autistic yourself. This poster was presented at a recent anaesthesia meeting. Now, I'm obviously not the first autistic doctor, I'm just one of the first to talk about it. And 3 years ago, I didn't know a single other healthcare professional who was autistic. But since I founded the Autistic Doctors Support Group, the growing membership supports my view that there are many of us, because medicine selects for autistic traits. And then when you look at the breakdown of specialties, this is from a spot poll a while ago, GPs are the most common, psychiatrists are second. And when you consider the relative numbers of GPs and psychiatrists, it's clear that autistic doctors are overrepresented in psychiatry. And those of you who use the DSM regularly may recognize Dr. Robert Spitzer. He died in 2015, and he was primarily responsible for the removal of homosexuality from DSM-2 in 1973. And to quote Alan Francis, that was the result of his single-minded and almost single-handed crusade to eliminate the psychiatric stigmatization of difference. His other major accomplishment was to save psychiatry from a crisis of credibility in the 60s and 70s by systematically developing the DSM-3 and its subsequent revision. I first read about him in Steve Silberman's book, Neurotribes. As I did, I noticed a lot that was very familiar. Now, this is a whole other talk, but briefly, to quote Steve Silberman, while Spitzer's eccentricities may have fallen short of meeting the criteria for Asperger's, the DSM-3 was the product of a mind that exhibited many classic qualities of autistic intelligence. Wouldn't it be the most supreme irony if the man who created the Bible on which modern psychiatry is based was one who thought like us? What more evidence could we need that diversity of thought within medicine is vital and that we need to recognize and celebrate neurodiversity? But let's move on to healthcare. We know from several large studies that autistic adults experience worse physical and mental health than non-autistic people. And at this point, I should say that if you haven't heard about our healthcare outcomes and our mortality statistics, including our suicide risks, then this could be upsetting, particularly if you're autistic or a parent. The figures I give, it's important to remember this, the figures I'll give relate to the autistic population as a whole and do not indicate outcomes for individuals. While of course autism is not a mental illness, it is associated with mental health, co-occurring mental health conditions in up to 80%. So anxiety, depression, bipolar disorder, OCD, eating disorder, substance misuse, all very common. Missed and misdiagnosis is a particular issue for women. And we know that in particular, borderline personality disorder is a frequent misdiagnosis. Suicide's an autistic crisis, with rates for autistic women up to 13 times the general population rate. And figures in the literature of 2/3 having contemplated and 1/3 having attempted suicide. 15% of those hospitalized after attempted suicide have a diagnosis of autism. And a psychological autopsy study shows that 11% of those who died by suicide had evidence of autism. For current thinking around psychiatric illness in autistic adults, I'd recommend the Royal College of Psychiatrists 228, published last year, available to download from the college website. And I'm proud to have been a member of the working group that produced the report. Moving on to my own work in this area. This is a study undertaken in collaboration with Professor Louise Gallagher and As I Am, and we looked at the experiences of autistic adults attending 𝗖𝗖, which is a residential conference held annually in the UK, organised by and for autistic people. And while the qualitative data is awaiting formal thematic analysis, I'll present some of the preliminary quantitative data. 18% were attending a psychiatrist at the time of completion, 61 having attended in the past, and 43% described difficulty attending. Now, this project is moving more slowly than I had hoped, mostly because it's just so painful to work on. How have we reached a situation where we, as a community, are so marginalized and so misunderstood that 86% of us have felt that life is not worth living? 47% of the respondents had attempted suicide at some point. 65% had engaged in self-harm, which is not something that's widely associated with autism amongst healthcare providers. And for 21%, this required medical attention. And few of my colleagues treating patients following an episode of self-harm would consider autism. 27% had been psychiatric inpatients. 11% had been detained under mental health legislation, with 10% experiencing restraint. 28% said they used alcohol to manage mental health issues, with 11% using illicit drugs. And while most of us are familiar with the mental health challenges, the mortality gap and the physical health conditions associated with autism are less well known. Some of you may be familiar with the 𝘱𝑭𝘢𝘂𝗿𝗂𝗏 study, where they looked at a large population-based cohort of 27,000 autistic people in Sweden. They examined all-cause and cause-specific mortality and found that the mortality rate for the autistic group was 2.5 times the general population rate. Other studies from Scotland, the US, and Australia show similar patterns. And there's also a recent paper showing that even our in-hospital mortality rate is doubled. So while the average life expectancy in the Swedish study was 70 years, for the autistic group without intellectual disabilities, it was 54. That's a mortality gap of 16 years. And for those with co-occurring intellectual disability, average life expectancy was just under 40 years. And the leading causes of death in the autistic group were heart disease, suicide, and epilepsy, but in almost all the diagnostic groups, including cancer, lung disease, endocrine disease, mortality rates were increased for the autistic group, except for infections, which is interesting in the context of the current COVID crisis. Autistic people experience higher rates of conditions such as diabetes, obesity, high blood pressure, high cholesterol, stroke, epilepsy, Parkinson's, sleep disorders, digestive disorders, and more recently recognized Ehlers-Danlos or hypermobility syndromes. It's known that autistic people face healthcare inequalities with access barriers due to patient-provider communication difficulties, sensory issues, executive functioning or planning issues, as well as prior negative experiences with healthcare, which is an independent barrier to future care. Autistic patients are 3 times more likely to attend emergency departments, 3 times as likely to be admitted from an emergency department, and most worryingly, 3 times as likely to die after an emergency department presentation. So we must ask, is this because autistic people delay seeing their own doctor or have no doctor, and therefore present later in the natural course of an illness? My work in this area started as part of the As I Am Clonakilty Autism Friendly Town project in 2018, where I was asked to develop autism training for healthcare providers. And to ensure the training was informed by the lived experiences and the concerns of the autistic community, I undertook a discussion workshop and survey at 𝗖𝗖, followed by an online survey comparing autistic adults, parents of autistic kids, and a control group. And we asked, what are the barriers faced? What do our GPs need to know? What works well? What would make visits easier? And what are the self-reported consequences of delayed care? Our paper is currently in review, and while I don't have time to go into the results in detail, a preprint is available on medRxiv, and hopefully we'll have a peer-reviewed paper soon. We had 860 respondents, most of whom were autistic, with 74% having a formal diagnosis. We asked, do you have difficulty visiting your doctor when you need to? Not in general, but when a visit is actually required. And over 3/4 of the autistic group, half the parents and 1/3 of the controls said yes, they had difficulty. 78% of autistic respondents avoid using the phone in general, and this is the most common barrier to accessing healthcare. This isn't something that's widely appreciated outside of some specific autism services, and it's one of the most urgent areas to address. If your service relies on telephone contact and you don't offer an alternative, then that service is inaccessible to a majority of autistic people. 55% do not attend a GP when required because of not feeling understood. So they just don't go. Sensory issues, executive functioning issues, and concerns around disclosure also featured prominently. Let's focus on communication for a minute. 72% said anxiety makes it harder to communicate. And this is true in all aspects of life for autistic people, and specific measures to reduce anxiety would have enormous benefit in the context of healthcare. And as autistic people, we know this. As professionals, we see it, but how often do we make adjustments? Do we assume this is a patient's baseline? Concern at not being believed or taken seriously is a significant barrier. And given the non-presentation of serious illness, which I'll talk about in a moment, it's a specific challenge to address. The communication differences which are inherent to autism can pose really particular challenges in a healthcare setting. Expressing emotions differently, such as appearing to be angry when afraid or in pain, or describing pain without the expected non-verbal signs of pain, can lead a doctor to underestimate the level of distress. But here, just look at the intergroup differences for none of the above. When we asked how often communication difficulties were encountered during a consultation, 90% of autistic respondents said all the time, frequently, or sometimes. Executive functioning is an issue. Over-inclusiveness is common. Difficulty knowing what's serious, what's not, what to include, what to leave out. Difficulty summarizing, and just a sense of needing to give the whole story can be a challenge, particularly in a short appointment. And as a healthcare provider, I know it can be difficult to manage, but being able to email in advance the reason for the consultation would effectively deal with this problem. Again, look at the intergroup differences for none of the above. Because the difficulties we face in managing to arrange and attend a medical appointment are just simply not experienced by non-autistic people, and therefore they're often not understood. So what helps? A preference for online booking was shown across all groups, but next most important, as I've mentioned, for the autistic group was the ability to email in advance the reason for the visit. Being allowed to wait outside should be easy to accommodate, particularly post-COVID, as would an appointment at the start or the end of a clinic. The consequences of access barriers to healthcare include untreated physical conditions, untreated mental health conditions, late presentations, emergency admissions, more extensive treatment or surgery. And most worryingly, a third of autistic respondents reported a potentially life-threatening condition which went untreated due to inability to access healthcare. And many autistic adults have no access to primary care whatsoever. And there were no differences with or without formal diagnosis in terms of difficulty attending, barriers faced, or adverse health consequences. So based on this research, I believe these are important factors contributing to the excess morbidity and mortality for the autistic community, and they're the most urgent to address. So what does this mean in an Irish context? Potentially large numbers of Irish autistic adults, many undiagnosed, facing significant barriers, significant challenges accessing basic healthcare, and likely to be experiencing increased morbidity and mortality. And yet outside of the intellectual disability services, we're an invisible cohort in Irish healthcare. We urgently need to develop diagnostic and support services for autistic adults as part of our public health system. It's deeply concerning that a condition with such profound health impacts currently receives no funding or provision in primary care, secondary care, or social services. Both of my surveys show a worryingly high rate of autistic people not registered with any GP. The greatest barrier is the phone, and so I'm particularly concerned about our community during COVID with the move to telehealth. This is a matter of human rights. Equality legislation requires that accommodations be made. So, for example, failing to provide an alternative to use of the phone to access your service is potentially a breach of your duty under the Equality Act. But it's not just a legal requirement, it's a moral duty. We would never deny a wheelchair user access to healthcare services for want of a lift or a ramp. Accessible communication alternatives to the phone are equally important for autistic people. It's vital that we accelerate the move towards a strengths-based approach to autism and resist the tragedy narrative that's so pervasive across healthcare. Education and training will be required for all staff in both physical and mental health care, and this must be informed by the lived experience of autistic adults. It's ideally developed and delivered by autistic healthcare providers. So we need to challenge the assumption that we can often have as professionals that autistic people are our patients, our clients, and recognize that autistic people number among our colleagues. Making healthcare services autism friendly involves first recognizing, valuing, and learning from our autistic colleagues. The way to join the Autistic Doctors private group is to send a message via the public page. Follow us on the public page for updates. You can find me on Twitter, where I tweet as the Autistic Doctor, or feel free to email me directly. Thank you.
Thank you, Mary, for that excellent presentation. And that brings us up to our first break. So during the break, you might wish to submit a question for our panel. So don't forget to use the Q&A function button at the bottom of your screen. So please join us here in 5 minutes when we'll hear from the remainder of our presenters, and we'll have our panel discussion. Welcome back. Hopefully you had enough time to grab yourself a cup of tea. So I'm pleased now to introduce our next contribution from our colleague within the Autistic Special Interest Group of the PSI, 𝗖cie Doyle. Jessica is an autistic researcher with a passion for engagement in psychological research on autism. She's an honours BA in psychology from Trinity College. Currently her focus is on research into autistic perception from a predictive coding lens, so linking perception, cognition, and anxiety in autistic adults. Jessica was a founding director of Galway Autism Partnership, where she developed, facilitated, and advised on the Special Interest Model Youth Cafe and designed the Gap Sensory Room. Jessica enjoys linking and uncovering patterns, hypothesizing and investigating theories, as well as experimenting with translating findings into applicable practice, such as our prototype outdoor sensory space and the Autism COVID-19 Individual Health Action Plan. Tonight, Jessica will summarize her ongoing international research into perception, cognition, and anxiety in autistic adults. She'll explore the predictive coding model of autism that prompted her investigations and inspired her prototype outdoor sensory space designed to reduce uncertainty.
I'll start off with a little bit about me. A lot of talks I've heard start with a baby picture, so I thought I would do the same. Here I am at 8 months. I was diagnosed with autism at 17, but I think my mum guessed way before that. So far, I've often found myself on a bumpy, winding path. I've lost hope more times than I can count. For so long, life was terrifying and sad and loud and uncertain. So much so that I didn't finish school. I felt so disconnected to everything, with me locked inside and a multitude of masks on the outside. All I wanted was a way for me to be me. I am now in a really great place. I am working as an autistic researcher, doing what I love to do. And most recently, I've started as an assistant psychologist at the adult autism practice. I never thought I would find a position like this where being autistic is seen as a strength. My next adventure will be working on TCD's sensory processing project, and I can't wait. When it comes to research, I'm really passionate about bridging the gaps between theory, research, and practice, or the why, the what, and the what now. In this presentation, I'm going to give a brief description of my research, only a section as I'm still analysing all the data, and I'll be looking at the why, the what, and the what now. While I find theory fascinating, I can see how many may not. So to avoid boring you all, I will only explain the basics. If anyone would like more details, please email me. The research I conducted explores the links between perception, cognition, and anxiety in autistic adults, specifically based on Van de Crew's Hippia Model, which stands for High Inflexible Precision of Prediction Error in Autism. Hippia is a hierarchical predictive coding model of autism. Hierarchical what, you may ask? Hierarchical predictive coding models of the brain propose that the primary function of the brain is to minimize prediction error. In this instance, we can understand prediction error as surprise. So these models suggest the number one function of the brain is to reduce surprise. Hierarchical predictive coding models suggest a mechanism of how perception works. As seen in the diagram, on the left, perception in green is created by a combination of predictions based on our past experience and beliefs and by sensory stimuli. We can see in the example of sound waves on the right, the red line is the actual sound, the blue line is what we expect the sound to be, and then the green line is what we actually perceive. There will always be some level of surprise, as two situations are never exactly the same. But not all differences are important, so we need to be able to decide which surprises are worth paying attention to because we can learn more from them, and which surprises should be ignored because they are just noise. It is at this crossroads that the Hippia model comes in and proposes a fundamental difference in the evaluation of prediction errors that is distinct to autism. See the red path on the left at the crossroads of what to do with prediction errors. For neurotypicals, this path is used often. Many prediction errors are ignored and considered irrelevant noise, and perception is determined much more by beliefs and past experience with little sensory influence, which means quite often they can miss many of the details and richness of what is actually there, as they tend to evaluate this as just noise and ignore it. However, the upside to using this path does mean they are less susceptible to sensory overload. For autistics, this red path is used less. Autistic perception reflects a more accurate view of the world, one rich in detail and influenced less by belief and past experience. For autistic individuals, every sensory input not precisely the same as another is considered distinct and not counted as noise, leading to the generation of a highly complex internal model. The downside is that they are a lot more susceptible to sensory overload. As a simple example of the effect of this is spoon use. A neurotypical might see one spoon the same way as another, and using any type will mostly be the same experience. But for autistics, each spoon is noticeably different. A different weight means a change in coordination and how the food tastes. A different handle means a change in grip. So even something as seemingly simple as spoon use can create a highly complex model. For this reason, I prefer just to use teaspoons. They are light, dessert lasts longer, and I know what the experience will be like. The Hippia model proposes a definitive theory of autism. It suggests that the different weighing of prediction error, or different evaluation of what surprises are important and which should be ignored, define autism, and that all other autistic features are secondary to this. Hippia also highlights the functions of different autistic behaviors and the importance of context. Another way surprise can be reduced is through action. Repetitive behaviors such as stimming and other body movements provide controlled, predictable, proprioceptive feedback and are self-soothing as they create a sense of calm. They function as an important coping strategy to deal with and minimize prediction error. Context is important too. Autistic individuals often seek out and thrive in predictable environments. However, in volatile contexts, such as busy neurotypically designed environments, treating each new input as important and using it to update the internal model means continuously experiencing high levels of uncertainty and overload. This can lead to anxiety, and the lack of meaningful learning can contribute to frustration and depression. So I will now explain my research. If, as Hippia suggests, autistic perception is impacted a lot by sensory stimuli, I think it important to explore the effects of this on sensory sensitivity, ways of thinking, and the impact and experience of anxiety. So guided by the theoretical framework of Hippia, I designed and conducted research to explore the relationship between sensory sensitivity, cognitive style, intolerance of uncertainty, and anxiety in an autistic adult sample. The study used an online questionnaire with a sample of 486 autistic adults across 33 countries. 70% of participants had a formal autism diagnosis, and participants were aged 18 to 74 years old. As you can see in the graph, the sample consisted of 315 females, 89 males, and 82 other genders. Similar to my own experience, the graph shows that many participants reported high levels of co-occurring psychiatric conditions. This graph shows the percentage of each gender that reported conditions from each psychiatric category. A lot of participants reported more than one co-occurring psychiatric condition. As you can see in the graph, the yellow bar shows that some even reported 3 co-occurring psychiatric conditions. As well as reporting psychiatric conditions, a significant percentage also reported having other co-occurring conditions, such as Ehlers-Danlos syndrome, ADHD, epilepsy, and various other neurological conditions. Now for some results. The table shows that participants had high levels of sensory sensitivity, high levels on the 2 measures of cognitive style, systemizing tendency and local bias, high levels of intolerance of uncertainty, and medium levels of generalized anxiety. This graph shows the regression results. Results found that as sensory sensitivity increases, so does local bias, which is interesting because it could indicate that creating such complex models of the world has an impact on processing ability, and perceiving in detail leads to thinking in details. I'm currently analyzing the qualitative data collected on the subjective experience of autistic thinking, which will add to understanding this internal autistic experience. Results also found that higher sensory sensitivity was associated with higher intolerance of uncertainty. This may point towards a mechanism of perception to detect every new sensory stimulus as novel, leading to a constant state of uncertainty. And lastly, the biggest and expected result found that as intolerance of uncertainty increases, so does anxiety. It is crucial that autism practice is grounded in research based on theory. Even better is theory that attempts to understand the fundamental mechanisms that underpin the entire system. By continuing down the path of targeting specific features, such as social features, or creating domain-specific theories, such as theory of mind, we miss out so much and put too much emphasis on features that might only be a secondary feature. By looking at the perceptual level, we can really try and understand the primary mechanisms of the autistic system and appreciate it as a different yet valid neurotype. We really need to get away from research and practice that is grounded in a fixed idea of normal and from seeing autism as a pathology. I think it important that this changes at each of the 3 levels: theory, research, and practice. I think it vital we remember that these different ways of perceiving are just that, different ways of perceiving. Neither is more superior to the other, but similar to any system, context can have an influence. So we need to remember that this world has primarily been designed with neurotypical perception in mind. So research like this emphasizes how important it is that we adapt the world and make room in it for all neurotypes. Understanding autism as a perceptual difference helps us appreciate stimming behaviors and shows how important and amazing stimming is. We can see its important function in reducing surprise and highlight how these behaviors are a wonderful human adaptation to combat stress and create calm, rather than any sort of a disorder. This perceptual understanding of autism can impact on practice too. With the knowledge that context can have a lot of influence, professionals need to be aware that the predictable calm environment of a consultant's office or a therapeutic space often stands in stark contrast to the volatile, unpredictable, neurotypically designed environments of everyday life. Professionals need to know not to generalize their observation in one context to another. This is an important point, not noise to be ignored, because by generalizing, they can misjudge an individual's need for support. I want to talk now about a practical application I have created from this research. Over the first lockdown, I created a prototype outdoor sensory space designed to minimize surprise while encouraging an optimal experience and a playful environment that is accessible for an autistic neurotype. It's more functional than pretty at the moment because I was on a budget to keep the bees out. There is so much research nowadays on the benefits of fresh air and exercise for brain health. But still, most autistic spaces and sensory rooms are indoors. For example, I previously designed and built the sensory room that's indoors at Galway Autism Partnership. Outdoor spaces are often designed as sensory gardens, which are full of surprises and unpredictable flying insects, and not ideal for exercise, whereas general outdoor sports grounds and gyms are often very overloading environments. They can involve teams and unpredictable social interactions, and playgrounds are not typically designed for adults. For autistic adults, the proprioceptive input, this is the position of your body in space that you can get from playgrounds and exploring movement and senses, is just as important as we get older. So I wanted to design a space for that. The space is fully netted to minimize surprise. Adult-sized monkey bars provide proprioceptive input, though I can only hang from one rung at the moment, and a nest swing to provide vestibular input, which is your sense of body movement in space. I find vestibular input really calming, but also really good for focus. And I can tolerate the sound of people eating or making little noises much better when I've had my daily proprioceptive input. I use the space to get my needed input, which then increases my tolerance and productivity in other everyday, unpredictable, yet necessary environments. This prototype is a work in progress. I am currently adding new elements such as a water feature, an area to explore stimming through sound, and a covered area so I can use it in the rain. I also need to move it as my dad wants his lawn back. I do realize not every autistic person can build a sensory space in their garden, or even has a garden. So I'm really excited to hopefully bring some of the ideas from this space to my new graduate intern role I'll be starting in February with the TCD Sensory Processing Project. And hopefully in the future, there will be indoor and outdoor spaces in the community that are accessible to the autistic neurotype. That's about it, but just one more thing before I go. Something I really like is the deep crackling feeling of reflection, often accompanied by the shimmering possibility of growth. I enjoy the dance of growth, when my thoughts are challenged and I experience interactions and situations that force me to rethink something I thought I'd figured out. I think when it comes to autism and changing perspectives towards fully appreciating neurodiversity, that everyone, including professionals, could benefit from engaging more in this process. And I think they would find that it is a lot more fun than first expected, and that it can really have a wonderful impact on a lot of lives. Thanks for listening.
Thank you so much, Jessica, for that fantastic presentation. I'm delighted to introduce our final speaker of the evening now, Denny Burke. Denny is an autistic and ADHD inattentive type adult with co-occurring sensory processing disorder. She discovered she was neurodivergent in her late 20s after many years of misdiagnosis in the mental health system. Denny is a board trustee of Galway Autism Partnership. She's been involved in co-producing a peer-run out-of-hours HSC mental health cafe that opened recently. Denny is currently working as a peer connector in the Galway Community Cafe. Denny sits on other working groups within the HSC looking at best practice for treatment of adults that self-harm or are suicidal. Denny will briefly explore some common co-occurring differences in the autistic community. She will touch on why these differences and conditions are often overlooked and how many can be interconnected. Denny introduces the basics of neurodiversity and the social model of disability. She will talk about some approaches that may be helpful to support neurodivergent people.
Hello. Hi, everybody. I'm just going to share my screen now and get my slides up. So for some reason, when I put my slides up, it makes my video cut out. So it'll just be audio over the slides. So you'll be spared from watching me as well. So thank you for joining. So here's my presentation on autism and co-occurring differences. Before I start the presentation, I want to talk briefly about this picture here. So I've used this to try and represent the co-occurring differences. So some of them, they stand alone and other ones are overlapping and interplay with each other. So it can get a bit complicated, but we're complicated as humans are. So thank you for joining me. Now I'll just get on to my next slide. Okay, so my co-occurring differences. So I'm just going to give you a little bit of background to my story. So I was basically about 10 years in the psychiatric system, misdiagnosed. So I spent many years in and out of hospitals all around Ireland, and I went to a specialist hospital in the UK for a year. Yet despite this, it wasn't until roughly 4 years ago that somebody suggested to me that I could be autistic. So that was the start of a very interesting process for me. It really saved my life, but unfortunately, a lot of people don't have enough understanding and experience around autism and ADHD and other co-occurring differences, so it was missed. But so anyways, I got my sensory processing disorder diagnosis shortly after the psychologist had recommended I look into it. And roughly a year to a year and a half later, I received my autism diagnosis. And through that, I met other people in the autistic community around Ireland and internationally, which really opened up my eyes to a lot of different things, which made me also learn more about ADHD and how I identified with that too. So in recent months, I actually got my ADHD diagnosis as well. But I'm also dyslexic and dyspraxic. I don't have a diagnosis for either of those, nor will I seek one. But there's a lot of different things that interplay with each other. So those are the things that I was born with. But what I acquired was complex post-traumatic stress disorder. So unfortunately, as I mentioned, I had been misdiagnosed. So growing up not knowing that I was neurodivergent definitely caused a lot of mental health problems. And then my subsequent misdiagnosis meant that I didn't get the right treatment. So I definitely developed post-traumatic stress disorder from that, as do many autistics, as has been mirrored in people that have already spoken today. So it is really high in our community and unfortunately is undertreated and overlooked. But that is my co-occurring differences. So I won't, so sensory processing differences. So this affects touch, sight, hearing, taste, and smell. 94.4% of autistic adults have sensory processing differences, as was found in Crane et al. 2009. So every person has a different sensory profile. So my sensory profile means that I am hypersensitive to touch, to sight, to hearing, and to taste, but not to smell. But for somebody else, that could mean that they are hyposensitive to touch and maybe hypersensitive to hearing, and a different combination of them all. So everybody has a unique profile. And also every person, regardless of whether you have sensory processing disorder, has different sensory processing experiences. So it's not all that different. And there are really positive aspects to it as well. And as people have mentioned already, it's the environments that we're in that can disable us. So while I am hypersensitive to sound, I really love listening to music that I enjoy really, really loud on my headphones. And I'd be the first person right up at the front row at a concert. But if I was, say, in a bar or in a restaurant or a cafe and there's music on in the background and coffee machines going around thing, I'd find that really stressful. Or even just a radio on stuff that I'm not familiar with, that can be really overloading. So it's not as straightforward as somebody is hypersensitive to sound, therefore all loud noise bothers them. So every person is different. And yeah, so next slide. So ADHD, attention deficit hyperactive disorder. It's not really a great name and it doesn't really describe it all that well. So for ADHD, it's not an attention deficit, it's actually an interest-based nervous system. So it's just that it's inconsistent. So we pay attention to things that we are interested by, or if something is urgent, we tend to be good in emergency situations, or if there's something new or interesting, something different, we pay attention to that. So people can hyper focus sometimes for long periods, but miss other things that are going on. We can also have emotional hyper arousal. So people might say, I feel emotions intensely. Rejection sensitivity is also a common characteristic of ADHD. So people feeling a lot of rejection in different relationships, and then because they might have difficulties in communication, whether it's from autism or ADHD as well, that can impact on the rejection. So, and then it can play a cycle over and over. So a lot of autistic people that do have ADHD as well would have this as well. So there's massive overlap. And what I found as well is recently there are a lot of autistic people in Ireland learning more about ADHD and then realizing that they are also ADHD. So there's significant overlap. And a study that was done on children around autism and ADHD found that there was 59% co-occurring. Now, this could even be higher. It's hard to say. There's a lot of people that go undiagnosed and a lot of adults that don't get diagnosed till later in life. So I don't know what the true figures would be. And there's also a different name that Dr. 𝘦𝘷𝘦𝘯𝘵 has suggested called variable attention stimulus trait. So I find that could be a better name and a different way to think about ADHD, because there are positive aspects to it. Of course, it could be disabling in different ways, but it's not all bad things. So a trait could reflect the positive and the negative. And like all the other things that I'm describing today from around neurodiversity, there are positive aspects to it, as well as aspects that can be disabling. So trying to take both. Okay. So other co-occurring conditions, I won't stay on this long because a lot of this has already been mentioned by other people today, but I will just mention apraxia of speech is a co-occurring condition some autistic people can have. And that means people might have difficulty using their saying words with the lip movements and the tongue, so they won't be able to produce verbal words in the same way people without apraxia of speech could. So that is a barrier to verbal communication. And as a result of that, some people do get misdiagnosed with an intellectual disability. So unfortunately, intellectual disability can be overdiagnosed in the autistic community. Now, I'm saying absolutely people do also have intellectual disabilities, but I think often that can unfortunately be a misdiagnosis, and then people never get given proper communication tools when they would be able to communicate if given the right opportunities. But I will move on again because a lot of these have been talked about, but we do have a lot of co-occurring conditions that are overlooked and not treated. So missed or misdiagnosis. So from a study done on late diagnosed adults from Kondo 2015, he says 5 disorders, i.e. schizophrenia, psychotic disorder, bipolar disorder, major depressive disorder, and personality disorder were significantly highlighted as misdiagnosed psychiatric diseases or comorbidities responsible for unrecognized ASD, insufficient experiences of detecting ASD among clinicians. So sometimes it can be hard to tell whether something is one different disorder or else whether it is autism. So sometimes it's a misdiagnosis and other times people will have both diagnoses. But often because people don't know enough about autism, they will just look at the other conditions first and not consider autism. So the person doesn't get their autism diagnosis until a long time later. And usually that is because they have pushed for it themselves. And also from another study I'll briefly mention, there was a study done from 𝘖𝑦∗ in 2020 that looked at the median time elapsed between the first clinical evaluation by a psychologist or a psychiatrist and the ASD diagnosis was 11 years in males and 12 in females. And another piece from that study showed that the age at which the males got their first appointment was 11.5 years. And for females, it was 19. And that's interesting because that pretty much reflects my experiences as well. 19 was the first time I had my appointment in the psychiatric services. And it took me almost 12 years to get my ADHD diagnosis and just a little bit less to get my autism one. So it's quite concerning that people are having to wait so long to get a diagnosis. And what I will say as well is, sorry, I'm a bit nervous, so my voice is going a bit, so I'm not breathing enough. But no female autism, it doesn't exist. There's no female ADHD either. Unfortunately, females and non-binary people don't get diagnosed because they don't necessarily fit into this small box. And there's also plenty of men that also don't, and boys. So there isn't a gendered autism or ADHD or anything else. It's just that the box is written on very specific criteria that really isn't a whole picture of what ADHD is or what of autism is or any of those. So it's only, and all those boxes came from researching small boys. So just a small group of small boys. So they're not reflective of the whole population of autistic people and ADHD. But unfortunately, females do get misdiagnosed more often. So we need to look at that more instead of automatically jumping to borderline personality disorder. People need to look at, is it autism? Is it ADHD? Is it something else? Okay, cool. So a little piece on language. So I say I am autistic. I do not have autism. I am not a person with autism. I don't live with autism. A lot of autistic people don't like to be referred to as a person with autism. Many of us find that a bit offensive, and although that might be what you're told to say by other people, that's not really what many autistic people want to be referred to. Same for disabled. It's okay to say disabled person, not person with disability. So when I say that I'm disabled, I'm not reducing myself to a label. I am embracing a person and cultural identity that affects every aspect of my life. So it's a positive thing to embrace people's identity, not try and hide it away and act as if it's something temporarily part of them. It's part of me forever, and that's not going to change. So quick part on the social model of disability. So the problem is how society is arranged, not the disabled person. So only stairs with no ramps or lifts, inaccessible buildings and housing, inaccessible public transport, over-the-top health and safety, no sign language interpreters or accessible formats available, multiple barriers to employment, segregated schooling, discrimination and segregation. So as you can see, there's many barriers that we're facing. So yes, being autistic, having ADHD, all of these different things can be disabling in some ways, but mostly I'm disabled by society. So if society and the services we have to access could become more accessible, then I wouldn't be so impacted by these things and people would have a better quality of life. So neurodiversity, very quick intro. So neurodiversity is the diversity of human brains and minds, the infinite variation in neurocognitive functioning within our species. So that's a biological fact. The neurodiversity movement, however, is a social justice movement that seeks civil rights, equality, respect, and full societal inclusion for the neurodivergent. This is from Nick Walker from Neurocosmopolitanism. So some more terms. So neurodivergent, sometimes abbreviated as ND, means having a brain that functions in ways that diverge significantly from the dominant societal standards of normal. Neurodivergence, the state of being neurodivergent, can be largely or entirely genetic and innate, or it can be largely or entirely produced by brain-altering experiences, or some combination of the two. So autism and dyslexia are examples of innate forms of neurodivergence, while alterations in brain functioning caused by such things as trauma, long-term medication practice, or heavy usage in psychedelic drugs are examples of forms of neurodivergence produced through experience. So therapies. So different therapies work for different people, so I'm not going to say one size fits all, but I think if people could connect through interests, have a person-centered approach, be trauma-informed and compassion-focused, I think those are key elements. I personally found compassion-focused therapy the most helpful. I had DBT in the past, and I found that really unhelpful. There are aspects of it that I would absolutely use, as there are from lots of different therapies. There's helpful things. However, when it's used to the book, it can also be quite damaging. So I think we need to look at what behavioral therapies we're using on autistic people and neurodivergent people. Not all of them can be that helpful. They are for some people in different ways, but we need to remember that we're all different and just look at the person and just focus on the needs, not the diagnosis, because not everybody can get a diagnosis for various reasons. So yeah, we're all just human. Thank you.
Huge thanks to Danny for sharing her experiences with us. I'm pleased that Danny and our other speakers will be joining us very shortly for a panel discussion where we can address some of the questions that our audience has sent in. Just to remind you, there's a couple of people have put their hands up. Just to remind you, we can't actually respond to raised hands, but please put any questions into the Q&A button. Unfortunately, Vanessa won't be able to join us for a panel discussion, but any questions that have been directed towards Vanessa will be answered separately, and the answers will be put up on the website along with the talks. So just before the panel discussion, we're going to have another 5-minute break. So if you want to go stretch your legs, I want to see you then in 5 minutes for the panel discussion. Welcome back, everyone. It's now time to delve deeper into some of the issues that were raised during the presentation and highlighted by our audience. If the presenters want to just put on their mics and their videos, please, that would be brilliant. Okay, so the first question that came in, is there an evidence base for FBT with AN in ASD? Or what are the adaptations or treatment intervention for ARFID, anorexia, when autism is suspected or confirmed? I think that one would be directed at Faye. If you want to take that one.
Yeah, is that two questions or one? One is
two. The first part is there an evidence base for FBT with AN and ASD? So.
No, well, I don't know if anything specifically being done, but there's an excellent paper in Frontiers in Psychiatry in January by James Locke and Dasha Nichols, two experts in the field, just talking about how FBT is an excellent intervention for all sorts of co-occurring problems. I can't think of a better intervention because in FBT, the premise is about empowering parents to help their children. So it's not, you're not going into somebody for CBTE, for example, for an hour a week into a therapist. The treatment is conducted through the parents largely, and the parents are already making adaptations for their autistic child. And so in some ways, it's probably the ideal treatment for young people with anorexia, but I'm not aware of any research. It would be worth having a look at that article, though. James Locke and Dasha Nichols in Frontiers in Psychiatry, January 2021. It's an excellent account of how co-occurring conditions are taken into account in FBT, actually. And the second question, the second half of that, just maybe I have it here.
So what are the adaptations or treatment or interventions for ARFID and anorexia when autism is suspected or confirmed?
Okay. So the adaptations to treatments, the things like, well, this comes from the neuropsychological literature, but also the qualitative literature, where autistic people tell you what adaptations might have been helpful in their treatment sort of after the fact, and clinicians. There are two papers by 𝘦𝘩𝘬𝘬 and 𝘛𝘩𝘪𝘴 that and they say that things like literal language, the use of literal language, could be an adaptation. Of course, it depends on the presenting difficulty and the person's own needs. Things like longer processing time would address some of that. An awful lot of psychotherapy is really language laden, and we ask people with potentially executive function difficulties to do things like record their thoughts and to write down what they're thinking and to think of this and to diarize and to do all these other things that are actually really difficult if you have difficulties with executive function. And so adaptations with those sorts of difficulties in mind. Written communication is something that's come up in some of the qualitative literature rather than verbal, and that I think it might have been Mary that mentioned that. I'm not sure if it was Mary that mentioned into the phone, and then the focus on thinking styles, and that would bring me on to kind of thinking about what I was talking about, cognitive remediation. So that would look at the central coherence, poor central coherence, not being able to see the wood for the trees. But then you could have there are some in the cognitive remediation therapy manual, there are exercises to address that. So it's about, this is pre-treatment. You help people with rigid thinking styles, for example, to think differently, and then you might go into an adapted CBT after that. Does that make sense?
Yeah, no, absolutely. Yeah,
I don't know if it makes sense. I hope it makes sense.
It was Mary who linked in, so linking into some of the stuff that Mary was talking about is some difficulties in communication. Yeah, so. Talking of Mary, next question maybe I'll direct to you, Mary. Is it, hi, I'd love to find out more about the link overlap of EUPD and autism. Can you have both? Does experience of trauma play a role in EUPD in autistic people? So again, there's kind of two parts to that. So.
Okay. This is a really complex question, and it's very much a hot topic in psychiatry. And there are various different opinions around this. Certainly psychiatrists who are autism aware will diagnose autism far more frequently, obviously, than those who are not autism aware. My personal view, it's probably the underlying diagnosis. And there is a paper from 2013, 𝘦𝘩𝘬𝘬𝘬𝘬, who would clearly state that autism is the underlying, the basic diagnosis, and anything else would be layered on top of that. Can you have both? Again, it's a very complex question. I'm not a psychiatrist, so I'm going to defer on that one, but I will say that a lot of psychiatrists that I know argue very vociferously about that question. But the biggest message is, I think, that borderline personality disorder, EUPD, it is one of the commonest misdiagnoses for women who are autistic. And the management is completely different. So it's really, really important to get that right.
Can I come in on that for a second? I think when it comes to like practically looking at undiagnosed autistic females and those with, or the criteria of borderline personality disorder, that they're very similar if you're not aware of autism and if you're not aware of masking. Because if you look at a female that presents maybe in a psychiatric service who a female who presents in a psychiatric service and they've got masks upon masks upon masks, and if you look at that and aren't aware of the mask, then it might look like they're not connected to their sense of self. And also when you mask so much, like it's exhausting, so that affects your emotions, and your emotions then go up and down. And you feel disconnected because it's not really you that's connecting to other people around you, it's the mask. So you don't feel connected. So that again can create emotional instability. But when you are aware then that masking is a thing and you can look underneath that, then the reasons for why the behavior might look similar, the reasons for the behavior is very different in autism than it is in the criteria for borderline. So I think it's just about being aware of the masking and how that can look the same, but that you can have lots of things that are the same behaviors, but for very different reasons. So it's needing to look underneath and see the reason why.
Yeah, absolutely. So really, you're both kind of saying the same thing, and that it really needs, like, there's a lot of debate around it, but it needs somebody to really know what they're doing and to know both conditions very well. It's not.
Can I say something really quick on that as well? Just that myself, as I've said, I was misdiagnosed with that, but nearly, like, I'm not going to say all, because there are very few who I've met that haven't, but I know a lot of autistic people, women, who, like, there's very few that have not received that diagnosis at some point in their lives. So for some people identify that they do have both, and some people say that they have one or the other, and some people lose their diagnosis like I did. But people are socialized differently. So women are socialized differently to boys, and their behavior is excused because boys will be boys, whereas women, it's pathologized quite differently. So that's what leads as well to the misdiagnosis.
Okay, so next question. So again, I think this one is directed to you, Mary. Also, what supports or treatments other than antidepressants can autistic people with mental health conditions expect or request? And that was directed to Mary, but I think anybody could probably give their view on that one.
Yeah, I think the most important thing about receiving an autism diagnosis is that it allows us to understand ourselves and reframe our view of the world and of ourselves. And for most people that I know, it is really, really positive experience, not necessarily immediately, but really positively. And there are so many autistic people that I know who have had really significant mental health issues throughout their lives. And then suddenly a couple of years after diagnosis, no longer needing such intense mental health support. And that's borne out in the numbers from my survey. One thing to mention that I think is really important, really exciting in terms of medication, particularly because I mean the anxiety, the depression, that will always be a feature for so many of us. I think psychogenomics and personalized medicine is a really exciting area of research at the moment. And And just the idea of being able to test for what is the most likely to work antidepressant and basically get it right first time, rather than trying all the various antidepressants that are available. I just think that's really exciting. So I'm hopeful for that field.
Jessica?
Can I come in again that for a second? I just think one of the really important things for me was getting, like, as Danny said, we all have our own sensory profile, and getting to know your sensory profile is really important. Because for ages, I was really angry and I was really agitated and I was really anxious and I was really depressed, and I didn't know what was going on and I didn't understand it all until I really understood my sensory system and realized that so much of it had to do with that. And from understanding my sensory system now, I'm really able to know, like, understand, like, for a while I would use things like 𝘦𝘩𝘬𝘬 fidgety toys and stuff because I thought, sensory system, that just means I'll use what's out there already. But I didn't realize that stuff was making me worse, because I thought when I was feeling like low and I was feeling depressed and I was feeling numb, I thought that I needed stimulation to help me, like, feel more things. But it was getting to know my sensory system, I realized that those type of things just make me worse. And really what was happening is I'd gone so far up that I was gone past shutdown, gone into numbness, and I needed things to bring my system back down and to calm me down. And since I've started my mental health has got way better. So I think knowing your sensory system is really important as well.
Excellent. Excellent. Anybody else want to, Faye or Danny, do you want to come in there?
I'll throw in a few words. Yeah, I'll kind of mirror what Mary was saying about, like, getting the diagnosis can be life-changing, and I mentioned it in my presentation briefly, but it literally has. Like, I was one of those people that Mary talked about in the study. Like, I'd been restrained, I'd spent sometimes, a couple of days in a room with nurses and I wasn't allowed leave. I'd been in secure wards, all of these things. I was very, very seriously unwell. And there's no way I would still be alive had I not gotten the autism diagnosis and the other subsequent ones as well. But so it really is life-changing, and the kind of barriers that people are facing to that is just enormous, and it does really lead to a lot of suicides, and unfortunately not everybody makes it. I did, but it does really change lives. And as Mary said, it's not overnight, it's over time. I'm 4 years down the road after my autism diagnosis, and my life is very different now to what it was before. I'm actually planning for the rest of my life and enjoying my life. And I'm a lot kinder to myself than I was before, because when you're ADHD and autistic and all these different things, it's a bit easier when you're not and you're in conversations. You can maybe plan what you're going to say, different things like that. I can't. I don't have a filter. I can't script. I've lovely words in my head, but that's not always what comes out. And I used to beat myself up over those kind of things, which leads to massive self-esteem difficulties. But I'm actually a lot kinder to myself now, and I think everybody needs to be a bit kinder to themselves around that, because there's nothing I can do to control it. And there's so many aspects like that lets you reprocess your life and make sense of things in a different lens and kind of go, okay, I'm just doing my best. There's nothing else I can do. So if we can all just be more compassionate to ourselves in the whole process. But it's a very stressful thing, and there's many places along the process that people will fall off and feel, that's it, I'm done. But if people can keep going, keep getting support and connecting with people, hopefully we can move in better directions.
Danny, and I agree. I think the most powerful work we do clinically is not in a 50-minute session with a psychologist once a week or with a therapist once a week. It's how we help young people in particular to how attributions, if we can help with the identification and diagnosis, and then we can help to change the attributions of people around you and how they might scaffold your difficulties, rather than getting into trouble for having executive functioning problems, rather than being thought of as curt or rude, rather than the whole new junior cycle curriculum, which is based on project work with people you don't know in your year, where young people with autism are at a massive disadvantage. So anything that we can do in a young person in the rest of the week, in the 50 minutes they're not in the room with the psychologist, I think is probably of much greater benefit than adaptations you might make to CBT for 50 minutes and 12 sessions or something. So I think the treatment is about changing the system as much as it is about anything else.
Yeah, totally agree with you there, Faye. So there is actually a question directly for you, Faye, there, if you wouldn't mind taking it. Can you explain the point about alexithymia at the end of Faye's slides, wondering how this might be key to understanding the link between ASD and anorexia?
Okay, so alexithymia is the difficulty in identifying your emotions, and this is a study that was done with a non-clinical population, just as a caveat, but it's still very interesting. It looked at whether alexithymia might be the key to the risk of eating disorders in women with autism. So it's the difficulty, as I say, identifying and labeling your own emotions, and it's been found in as many as 77% of women with anorexia, and it's also obviously a feature of autism. And they found that those with autism and alexithymia are at a greater risk of eating psychopathology, and they posit that maybe it exacerbates social difficulties. So if we go back up to that model that I showed earlier on, of maybe how AN and ASD interact, then maybe social difficulties in school. We know young women with undiagnosed autism, the transition to secondary school and the way the social rules change, the extra stress on your executive function, all of that, and then your alexithymia your difficulty labeling your own emotions associated with that thing could make it more likely that the stress associated with that could lead to restricting, because restricting is great because it numbs all those negative emotions that you maybe have difficulty even identifying. I mean, obviously it's a lethal strategy, and anorexia is associated with the highest rate of mortality of any psychiatric illness, but that could be, in the short term, it is actually very effective at helping to manage emotions that maybe you're struggling to label or identify. But as I say, that's at an early stage, that research.
Brilliant, thank you so much. So I think we just have time for one quick question. So it's probably not really a quick one, I'm not going to give it to you, but I just kind of throw it out there maybe to everybody to have a think about. So should we be screening everyone attending CAM services for autism?
Well, I start. That's close to my heart. We are in our service, certainly. There are screening questions. We fall down with girls. We are learning every day that passes more and more and more. And there are 3 members of my department organising this event, which I'm very proud of. They are educating the rest of the department and the rest of Lucina, and events like this are just fantastic. We are screening, we're missing girls, and we know we are, and we're much more mindful of it than we were, I think. But also and the research is and the lived experience of people in clinic are influencing us in that sense. So we probably have a very cursory screen, but at the same time we are screening everybody who attends CAMS for AD.
Probably need to develop,
and obviously have no barrier to criteria for CAMS, which is moderate to severe mental health condition. That's just our CAMS teams. I can't speak for all CAMS.
Thanks, Faye. Jessica, were you going to say something there?
Sorry. Yeah, we probably need more screening tools that aren't so biased towards males. That would probably help in screening for females as well. Just more awareness of female, or sometimes it's the female presentation is also the male presentation, but different presentations of autism rather than the stereotypical.
Yeah. And one of the questions are, in relation to that, is if so, what screening tools can we use?
Not sure if there is any.
Develop them by autistic people.
Develop them, yeah.
Yeah.
People with professional.
Yeah, I agree. By autistic women, I think, actually. Yeah. No, so our this
both, I think, would be good.
Our questionnaire screening measures almost never pick up ASD in girls, but we do have other screening tools in our intake assessments.
Great. Okay, I'm just conscious of the time. We're just coming up to 2 minutes, so I just wanted to check in with everybody. Is there anything, last thing anybody would like to say that they haven't got an opportunity yet to say? No? Okay, well, thank you all so much. It was really, really good. And it was really nice to hear people talking about, you know, the place they're in now being better than, you know, before their diagnosis. And thank you so much for sharing your experiences and all the information that you've provided tonight. So unfortunately, that's all we have time for this evening. So I want to really, really sincerely thank you all for contributing tonight. It was a really good event tonight. We'll do our best to get the recording of the event online at the 𝘛𝘩𝘪𝘴 Research Foundation.ig as soon as possible. Just want to also remind you about our next and final event in the series, which takes place next Wednesday, the 10th of February, and it will focus on neurodiversity in the workplace. So please visit the PSI events page to register for the event if you haven't already done so. And if anybody requires CPD points for tonight, please email autism@𝘖cie⁴ and we can get them sorted for you. So again, all that's left to say is thank you all so much and looking forward to seeing you all again next week. So thank you and good night.
Thank you. Thanks.